Guys, so today we are going to continue our book club with the third meeting. Today is chapter 3, I think, the fundamentals of diagnostic radiology, the fourth edition. Today we are going to talk about cerebrovascular disease, and it will be presented by your colleague, Dr. Abbas. تفضل Dr. Abbas.
Thank you very much, Dr. Ahmed. Hello, everyone, and welcome. Today we will try to discuss cerebrovascular disease. What is a stroke? Stroke is an abrupt interference, non-traumatic interference of cerebral dysfunction. It's caused by mainly by infarction, comprising about 75% of causes of stroke, and another one by hemorrhage, which is comprising about 25%. So stroke is a clinical term applied to any abrupt non-traumatic brain insult. At first, we will start discussion about infarction. What's infarction? Infarction is a permanent injury that occurs when the tissue perfusion is decreased long enough to cause necrosis. It is typically due to occlusion of the feeding artery. Here we summarize the causes of infarction, the common causes of infarction according to the age. Here in pediatric, at the top, there is congenital heart disease, second, blood dyscrasia, and meningitis. These are in the pediatric causes of cerebral infarction. While in young adult, commonly due to cardiac emboli. Atherosclerosis becomes the second, and drug abuse, which is common in young age group, especially in the West, comprising the third cause of infarction in the young age group. In the elderly, atherosclerosis becomes the top, and the cardiac emboli became the second, and another one is coagulopathy. This is not written in the fundamental, but not written about acute, what is acute, subacute, and chronic. This is in another book I brought here. What's hyperacute infarction is defined as that within first 3 to 6 hours, while acute infarction within 6 to 24 hours. Subacute from 24 to 6 weeks, but subacute divided into yearly subacute, which is usually from 24 hours to 1 week, and late subacute from 1 to 6 weeks. After 6 weeks, it's regarded as chronic infarction. We have so many terms like TIA, which is defined as a sudden loss of neurological dysfunction with complete recovery within 24 hours. Imaging time course after brain infarction. When infarction occurred, within the minutes, the CT, there's no change. So CT is normal within the first minutes of occurring infarction. Well, in MR, it could be seen as a absent flow void, because later we will discuss that in the major arteries, usually there is flow void normally because of the movement of the blood within them. But when there is occlusion or there is slowing flow, it results in absence of the flow void. Another sign of the MRI within the minutes on infarction is arterial enhancement, which starts usually from 1 to 10 days. Arterial enhancement due to occlusion. Diffusion weighted image also could be high signal. within the minutes of infarction. So it is the most sensitive imaging test or the most sensitive sequence. After within the 2 to 6 hours, the CT became abnormal, like hyperdense arterial sign. Hyperdense arterial sign and insular ribbon sign also could be seen in the middle cerebral infarction. Later, inshallah, we will talk about insular ribbon sign. While in MRI, within 2 to 6 hours, there is brain swelling, which manifests as low T1. With subtle T2 hyperintensity also could be seen within 2 to 6 hours. There are many terms like cytotoxic edema. The main thing here is to discuss, you have cytotoxic edema and vasogenic edema. Cytotoxic edema usually due to brain cell swelling, causing efflux of the potassium and influx of the water, calcium, and sodium inside the cell and causing swelling of the brain tissue cells. It peaks from 3 to 7 days post-infarction and is maximum in the gray matter. This is cytotoxic edema. A smaller component of vasogenic edema also develops as the more resistant capillary endothelial cells lose integrity. In contrast, tumor associated with edema is primarily vasogenic and preferentially affect the white matter. What is insular ribbon sign? In CT, subtle but important blurring of the gray-white matter layer of the insula as a result of early edema due to infarction or ischemia in the middle cerebral artery. This is what's called insular ribbon sign. If you're comparing the left, you can see the gray matter and white matter, and it could be differentiated, but in the right side, we cannot differentiate between white and gray matter due to edema at the early stages of infarction. This is called insular ribbon sign because it affects the insula. This is applied by the middle cerebral artery. Another sign is light bulb sign. It is hyper-intense signal on the diffusion-weighted image precedes T2 hyperintensity, which typically develop 6 to 12 hours. So after 6 to 12 hours, there is T2 hyperintensity, but within the first hours, 2 to 6 hours, there is light bulb sign of hyperintense signal of the diffusion-weighted image, such as that. In this T2 weighting image, there is subtle hyperintensity seen in the region of the middle cerebral artery territory, while it's highlighted or it's more obvious in the diffusion weighting image. And this is a corresponding ADC map, which is showing a hypointense signal. These hyperacute signs primarily related to the morphological changes in the vessel rather than density or signal changes in the parenchyma. Such as hyperdense artery sign, as we said previously. On CT, the actual thrombus may occasionally be seen in the larger intracranial branches. This is in CT, hyperdense artery sign, but in MRI, there is flow void. Flow void on MR, the normal black signal of flowing blood within the lumen is immediately lost and may be replaced by abnormal signal representing clot or slow flow. From 6 to 12 hours, CT finding either sulcal effacement or sulcal blaring, decreased attenuation. So after 6 hours in CT, abnormality could be decreased attenuation. In AMR, after 6 hours, T2 hyperintensity could be obvious. From 12 to 24 hours, in the CT, again, there is decreased attenuation. In MR, there is T1 hypointensity could be seen, beside T2 hyperintensity. Yes. Yes. From 3 to 7 days, maximum swelling could be seen in both CT and MR. In CT, swelling result in decreased attenuation. In MR, T2 hyperintensity and T1 hypointensity could be seen. This is another example of infarction in the left medial cerebral artery. Here in the CT, if you're comparing both sides, there is sulcal effacement. Sulci, they are present here and could be traced, but in the left side, there is mild sulcal effacement, mild loss of gray-white matter differentiation, and in T2, subtle hyperintensity could be seen in the same region. In diffusion weighting image, which, as we said, it is the most sensitive sequence. The hyperintensity could be obvious, and this is called the light bulb sign. In the ADC map, by the way, ADC map, it's also a real diffusion with no T2 shine or T2 low effect. In the flare, the hyperintensity signal could be seen. This is the hyperintensity just like T2, but as we suppress the normal CSF signal, it's highlighted in flare. These two sequences are called perfusion sequences. This is a mean transient time. If you see, there is a larger area of hyperintensity, and in cerebral blood volume, the corresponding hyperintensity in the mid-MTT could be seen as a hypointensity. This
Approving the artery, the blood will take longer time to go through this area. So the different transit time will be increased, okay, because it's not as slow. So the blood volume will also replace areas that have little blood volume or abnormal. And this we use them to decide whether is it possible to do thrombectomy or not. In the stroke centers, unfortunately, we don't have it here. So we are not seeing these.
So if you see these areas, which is far away from the nearby the signals seen in the T2 in the diffusion, these areas represent the areas of at risk of ischemia. So these penumbra, yes.
The areas that are still alive,
yes.
No treatment is done. Yes, the ischemic will not part.
So unfortunately, in this case, I think they did treatment, but the infarction is extended after this CT after, I think, 1 week. It's chronic. It's chronic. Represent the area that are at risk in the perfusion images. It now became infarcted and edematic. From 3 to 21 days, there is in CT, there is gyral enhancement, which is peak at 7 to 14 days. While in MR, general enhancement peak at 3 to 21 weeks, 21 days, usually in the form of petechial hemorrhage also present. So this time, when the blood-brain barrier disruption occur. So if there is loss of blood-brain barrier, there is enhancement, there is hemorrhage, could be seen simultaneously.
And the second week, plus minus. All of them will show some. So you should expect enhancement and recent.
From 30 to 90 days, this is a chronic phase. In the CT, you can see encephalomalacia, loss of enhancement, because blood-brain barrier return to be intact in this state, and there is resolution of the petechial blood or hemorrhage. In the MR, the same thing, encephalomalacia, loss of enhancement, and resolution of petechial blood. The subacute and chronic changes, we can see edema. Edema, as we said, it's hyperintense in the T2 EMR and low attenuation in CT. There is mass effect. It's either causing compression of the lateral ventricle or any other ventricle, or sometimes here you can see herniation of the brain due to large or severe mass effect. We have fogging effect. This fogging effect in the second week, mostly seen in the CT, but sometimes seen in the MRI. There is a balance between edema and proteinaceous tissue necrosis. So balancing one another misleading as a normal. So if you do CT or MR in the second week, you may, if you don't do contrast, you may see normal. Don't be highlighted. This is an example of fogging effect. If you see this T2 waiting image of this patient, there's no obvious abnormality, but when you did gadolinium enhancement or contrast, there is enhancement of this part of the temporal bone, which represent the area of infarction, and general infarction could be seen. General enhancement. Another feature is encephalomalacia. Encephalomalacia, as we see, loss of brain tissue, and there is edema and collection of the CSF, called encephalomalacia. There is ex vacuo dilatation in the chronic state. If there is loss of brain tissue, it will track the ventricles and leading to the dilatation called ex vacuo dilatation. You can see hemosiderin in the chronic phase due to accumulation of the later on due to hemorrhage. Valerian degeneration also could be seen, causing atrophy of the cerebellar peduncles. Another event of infarction is hemorrhagic transformation. Sometime after the blood vessels are occluded, when they are opened, the blood go to the site of the damaged endothelial cells of the artery or the vessel supplying this area, causing hemorrhagic transformation of the infarction. The peak time for hemorrhagic transformation is about 1 to 2 weeks post-infarction. 1 to 2 weeks. As we see, this arrow is pointing to the petechial hemorrhage. Again, you can see here, usually in the cortex, cortical region, or in the petechial form. It is not a global, such as in the primary hemorrhage we see later. Use of contrast in ischemic stroke. We have CT and MR contrast in the stroke. In CT, typically begin at about 1 week. The peak is at 7 to 14 days. This is in CT. While in MR, we have intravascular enhancement and parenchymal enhancement. Intravascular enhancement from day 1 to day 3 resolved by 10 days. This is an example of intravascular enhancement. Sometimes intravascular enhancement could be seen in the periphery of the infarcted area due to collateral supply. MR parenchymal enhancement, it may occur as early as day 1. Typically begin after the first week. Virtually all cortical infarcts enhanced by MR at 2 weeks. You have rule of 3. It appears, it says that the peak of parenchymal enhancement is 3 days to 3 weeks and resolved by 3 months. This is an example of parenchymal enhancement. This is a pre-contrast, this is post-contrast. At pre-contrast, you see this petechial hemorrhage. In a post-contrast, there is gyral enhancement. So this is a vascular enhancement, and this one, parenchymal enhancement. Some note about the territory of the infarcted area. So if there is infarction, our job as radiologists, we must specify the area of infarction with territory. Also, it aids us to differentiate between the other causes of these abnormal signal intensities. In the internal carotid artery, hemodynamic effect begin to be seen when there is 80% reduction in the area or 60% reduction in the diameter. This is an example of normal flow void seen in the internal carotid artery, while in the left side, there is a hyperintense signal corresponding to thrombus or occluded left internal carotid artery. And this is the corresponding angiography. There is tapering and occlusion of the left common artery. This is one other example of internal carotid artery dissection. This is a dissected part, and this small lumen is remaining internal carotid artery. This is also MRA, CTA, sorry. And in Doppler, it says there is a spectral broadening of the internal carotid artery. The most important one is middle cerebral artery. It supplies more brain tissue than any other intracranial vessel and is the host to almost 2/3 of infarction. Its offspring or its branches are the lateral lenticular striate, which supply most of the basal ganglia, and the hemispheric branches which serve as the lateral cerebral surface. This is an example of middle cerebral artery infarction, as we see previously. This is the cortical branch, which, as we said, supplies the lateral cerebral surface. Another branch of the internal carotid artery is anterior cerebral artery. It supplies the medial lenticular striate, serves the rostral portion of the basal ganglia, and also has a branch, pericallosal branches supply the corpus callosum, and hemispheric branches serves the medial aspect of the frontal and parietal lobes. This is an example of anterior cerebral artery infarction. This is hemorrhagic transformation, and this was the area of infarction. About 5% of infarct involve the anterior communicating artery or anterior cerebral artery. So this is not common like middle cerebral Basilar artery. Occlusion of the basilar artery itself is usually rapidly fatal due to infarction of the respiratory cardiac centers in the medulla. Occlusion of the perforating end arteries from the basilar artery causes focal brainstem infarction. These lesions characteristically respect the midline of the brain, so it's not crossing to the other side. It respects the midline of the brain stem and often extend to the ventral surface. Extending to the ventral surface, in contrast to metabolic disturbances such as central pontinomyelinolysis and hyperintense hemorrhage, most commonly in the pons, tend to be more central or diffusely located. Posterior cerebral artery yes. Posterior cerebral artery, 10 to 15% of it comprises 10 to 15% of infarctus. The posterior choroidal artery arises from the proximal PCA to supply the choroid plexus of the third and lateral ventricles and pineal glands. Also, PICA has a posterior cerebral artery, also has a cortical branch supply the infero-medial temporal lobe, superior occipital gyrus, and the visual cortex of the occipital lobe by the calcaneal artery. This is an example of the posterior cerebral artery infarction. You have posterior inferior cerebellar artery infarction. It arises from the distal vertebral artery. It supplies the dorsolateral medulla, inferior vermis, and the posterolateral cerebellar hemispheres. This is also the image showing infarction of the PICA. As we said, it is a dorsolateral medulla, inferior vermis, and the posterolateral cerebellar hemispheres. You have watershed or border zone infarction. Then I would like to some quick about quickly. Watershed areas are this diagram represents the watershed areas between the branches of the two major arterial territories. For example, between anterior cerebral artery and middle cerebral artery, it's supplied by the end arteries and are liable to infarction due to, for example, if there is generalized hypoperfusion, these areas are more susceptible to be infarcted, such as these changes and this one.
These areas will be the first one to go down. Because there are advantages in between. For example, anterior cerebral and middle cerebral arteries. So they are not taking enough blood from the anterior cerebral or from the middle cerebral. So the first one to go is the watershed areas. So that's why we need to know them. Okay?
Venous infarction is not common, but it's important to be because differentiate as a radiologist. Venous infarction, it may occur in any sinus or any cortical vein occlusion, and this MRI, this T2, both are T2. As we know, venous infarction is commonly associated with hemorrhagic transformation. because there is occlusion of the vein, and the artery pump more blood to the area, resulting in hemorrhage. We can see here different layering of the hemoglobin. The low signal and high signal are representing the hemorrhagic transformation of the infarction. This is the MRV, with or the normal or the T1, also the T1 MRI. You can see that there is the left straight sinus, transverse sinus occluded and appear as a high signal due to either thrombosis or slowing flow. And this is the MRV. There is absence of the left transverse sinus, indicating the occlusion of the sinus. Another important sign in a venous infarction is the empty delta sign. This is the sign present in the CT with contrast, because contrast feeling the normal sinuses, but if there is thrombosis, there is a flow void, there is a filling defect in the area called empty cellular sign. This is delta sign, yes. After 1 week of the same patient, they did MRI. We can see there is area of hemorrhagic infarction, and there is hyperintense signaling in the superior sagittal sinus. So it shift from infarction to hemorrhage. Evolution of the hemorrhage by MR. This is time. This represent red blood cells, hemoglobin state, T1 and T2 signals. From day one, there is intact cell membrane. There is oxyhemoglobin. It appears as T1 at T1 iso to dark. In T2 it is bright, so it is just like a CSF, and you can not see well. That's why CT is better than MRI for subarachnoid hemorrhage or other, if you suspect hemorrhage. From day 0 to 2, it's also RBCs are intact. There is deoxyhemoglobin there due to decreased oxygenation of the blood. It appears in T1 also iso to dark, and in T2 it is dark. From 2 to 14 days, also the cell membrane is intact, and there's intracellular methemoglobin. It appears as bright in T1 and dark in T2. While from 10 to 21 days, it becomes bright in T2. After 21 days, there is lysozyme and hemosiderin deposition of ferritin. It appears dark signal on both T1 and T2 signals. No.
So just summarize it. What hemoglobin is the troublesome one? If you see it bright on T1, this is hemoglobin. This is extracellular or extracellular, you look at the T2. When it is extracellular, it will be dark. When it's extracellular, it will be bright. Okay? So this is the idea. If you know them by how they work, you go for the
In hemorrhage, here we see, we talk about hemorrhage in non-traumatic patient. Of course, there's not concentrate on subarachnoid and concentrate on epidural or subdural. You have subarachnoid and parenchymal hemorrhage. The subarachnoid hemorrhage mostly due to rupture of perianeurysm, which often occur near the branch points of the circle of Wills. 85% from the anterior part of the circle of Wills, whereas 15% arise in the vertebrobasilar territory. Common locations include branch points near the anterior communicating artery, which occur in 33%, such as this CT. There is evidence of hemorrhage, and this is a CT angiography showing the aneurysm in the anterior communicating artery. Another common location is the middle cerebral artery, which occur in 30%, and posterior communicating artery in 25%. So subarachnoid hemorrhage is mostly due to ruptured perianeurysm or aneurysm. Flare sequence on the MR can improve conspicuity of acute blood, but CT still is considered the imaging method of choice when clinical findings suggest the possibility of subarachnoid hemorrhage. This is the CT finding of subarachnoid hemorrhage, and this is the flare, corresponding flare. There is signal hyperintensity seen in the flare because we suppress the normal CSF signal. It could be used for subarachnoid hemorrhage, but CT is the imaging of choice. And then when looking for subarachnoid hemorrhage, there are certain areas we must concentrate the dependent areas. For example, if there is a rupture in the anterior communicating artery or any other branch, we must, in the CT or MR, look for the areas of the dependent portion so as to look for the hemorrhage. Because, you know, subarachnoid hemorrhage is communicating with the ventricles. That's why it lay down in the dependent part, such as here seen in the posterior horns of the lateral ventricle, in the interpeduncular fossa, and in the insular also could be seen in Sylvan. The most sensitive area for detecting subarachnoid hemorrhage are the dependent parts of the occipital horns and the interpendicular fossa. No, طلعت. إن شاء الله I will try it. Parenchymal hemorrhage. The most common one is hypertensive hemorrhage in 35%. This is an example of hypertensive hemorrhage. Another one is vascular malformation, and in the vascular malformation you have too many causes. The AVM has become the first. This is the area representing the AVM and infarction. As we said, aneurysm causing subarachnoid, but AVM causing parenchymal hemorrhage. Another vascular malformation is cavernous malformation. Just see the image.
Cavernous malformation is a blood of different ages. When you see blood of different ages, this is cavernoma or cavernous malformation. Cavernous meningioma, cavernoma, cavernous malformation.
Venous malformation, or venous anomaly, or venous angioma, and telangiectasia, and occult cerebrovascular.
All of these, they call it occult cerebrovascular malformation.
If you cannot differentiate between them,
Cerebrovascular malformation.
these are other causes of parenchymal hemorrhage due to coagulopathy, due to drug such as cocaine, amyloid angiopathy, it's occurring in the elderly. And this is the differentiation between the benign or primary parenchymal hemorrhage versus the malignant one. I think we have no time. And we have primary with hemorrhagic transformation of infarction. Thank you.
Thank you very much. Very nice presentation, very concise, very precise, and very focused. It is very nice of you. Thank you very much.